next speaker is Dr. Vanisha Anand. She's going to speak on impact of laparoscopic myomectomy on pregnancy outcome.
Good evening, everybody. I'm Dr. Vanisha Anand, attending consultant in BLK Max Hospital. I'll be telling about the impact of laparoscopic myomectomy on pregnancy outcome. So, as we all know, uterine fibroids are common benign tumors which affect women of the reproductive age, and it is associated with infertility, miscarriage, and pregnancy complications. Lap myomectomy has gained popularity worldwide for fibroid removal due to its advantage over myomectomy, including shorter hospital recovery time, reduced blood loss, and lower risk of post-op adhesions. However, regarding its impact on pregnancy outcomes, particularly uterine rupture during pregnancy and during delivery, it is still debatable. We sought to evaluate the effect of myomectomy as a therapy for infertility and to define the factors that influence the reproductive success after lap myomectomy. So we included around 102 women who underwent lap myomectomy for symptomatic fibroid between 2018 and 24 in BLK Max. Patients were followed post-surgery and pregnancy outcomes were recorded. The inclusion criteria included women around 20 to 35 years of age and were diagnosed with uterine fibroids and infertility or recurrent miscarriage. Patients with infertility had at least one myoma of more than 6 centimeter. Pre-op evaluation was done and multiple myomas with other infertility parameters were included. Also, patients underwent lap myomectomy, attempted conception post-operatively. The exclusion criteria was presence of other infertility causes like tubular occlusion, severe endometriosis, and poor ovarian reserve, history of previous uterine surgeries, and patients who did not attempt pregnancy after lap myomectomy. So we collected demographic data, fibroid characteristics, surgical data, and pregnancy outcome, and we provided the insights into the relationship between surgical techniques, suture types, and myoma characteristics. So the age outcome among the number of patients were between 20 to 25, there were almost 30 patients, and the percentage was 29.4. Between 25 to 30, there was 35 patients, and the percentage was 34.3. And maximum was between the age of 32 to 35, that was 36.27%. And the number of myomas were the types of myomas: submucous, intramural, subserosal, and multiple. And the maximum percentage that was found was the submucous fibroids, which was 34.3%. Regarding the pregnancy outcome, spontaneous pregnancy was seen in almost 80.3% women, while out of the 102 women, 8 women underwent IUI and 12 out of them underwent IVF pregnancies. Mode of delivery, we saw that vaginal delivery was seen in almost 13% of the women, and LSCS, almost 86% of the women underwent LSCS. Among the vaginal also, women who had subserosal fibroid were there among the mode of delivery as vaginal. So average patient characteristics was the average number of fibroid size was removed, which was around 6 to 12 centimeter. Number of fibroids removed were around 1 to 10 per patient. The conception rate, as I have discussed previously, 76% conceived within 12 to 24 months post-surgery, and 82 conceived spontaneously, while 22 through ART techniques. The miscarriage rate was 1.9%, preterm was almost 29.4%. No cases of uterine rupture were recorded in our study, and the neonatal outcomes were mean birth score was around, birth weight was around 2.5 kg, and the ABGA was more than 7 in 97% of the neonates. So the mean age of women across these studies ranged from 30 to 35 years, with most studies reporting a mean in the mid-30s as it was done in our studies, and the studies exhibited diversity in the number of myomas per patient. The reason behind the choice of delivery can be multifactorial, including the history of myoma treatment, localization, and the size of the remaining myomas, and other obstetric considerations. Many investigators agree to a point that the presence of large myomas greater than 10 centimeter is a contraindication to lap surgery, but it depends on the expertise of the surgeon and the medical treatment before surgery to reduce the vascularity of lesions can be done. We did not, however, use GnRH agonist before surgery because we found no difference in the degree of surgical difficulty between 6 and 8 centimeter laparoscopic myomectomies. The use of multi-layer sutures as investigated in other Mayo et al. And Fukuda et al. Seemed promising, with later reporting no instance of uterine rupture among 48 participants similar to our surgery. Interestingly, Alexander's investigation into barbed and non-barbed techniques defines no uterine ruptures and indicating possible lower risk with these methods. The ideal time interval between myomectomy and pregnancy remains uncertain, and the shortest time from myomectomy to pregnancy was an average of 6 to 12 months, with a uterine rupture occurrence rate of 0% in our study. The finding of this study suggests that laparoscopic myomectomy significantly improves pregnancy rates in women with fibroids. The high spontaneous conception rates indicates that lap myomectomy restore the uterine function by removing the fibroid-related barriers to implantation. However, high cesarean delivery rates highlight the need for careful obstetric monitoring. Conclusion: the lap myomectomy is safe and effective surgical option for women with fibroid-related infertility. It is associated with higher conception rates and favorable pregnancy outcomes. However, due to the increased risk of cesarean delivery, close antenatal surveillance is recommended. A valuable alternative to abdominal myomectomy, lap myomectomy is still a challenging procedure and requires an experienced laparoscopic surgeon. For infertile patients, especially with unexplained infertility with myoma, lap myomectomy is an effective option for better pregnancy outcome. Thank you.
Thank you, Dr. Vanisha. Any questions?
But how much of the vasopressin that you use?
So we almost, for all the cases we used vasopressin, and that has significantly shown to reduce the blood loss during the surgery.
Okay, so do you use, if there is a endometrium gets opened up during the surgery, so how many layer of the suturing that you...
So usually we do double breastfeeding flapping technique, and usually we can even do with PDS Vicryl, but it is better if you have V-lock or you can do use barb sutures. That is again better, Stratifix or barb sutures.
Okay, any question from the audience?
No questions. Thank you, Dr. Vanisha. Thank you so much.